My pleasure. It's my pleasure to sort of be the host and the chairman today for this endoscopy part of GECHO, which is hosted by the Gastro Foundation in conjunction with ECHO New Mexico, the parent founder of the ECHO project, and also through ECHO India. These are part of our regular weekly Wednesday sessions, and they are involving today 78 registrants and from 12 different countries across the continent. So welcome to everyone who's logged in currently and those who will be joining us during it. And just remember that we would like you to interact with us, and that without a doubt, the best way to do that is through the chat box. If you have any questions, then I can put them to our speakers. I just have to state that for the minute in Cape Town, and I think in other areas in South Africa, we are in the process of load shedding. And unfortunately, Professor Goldberg is in a load shedding area as we speak. So we're not quite sure if he will be able to join us during this, but I think we will see how that goes. So it may be that we will only have the one talk from Dr. Sassa Botha. And Dr. Sassa Botha is someone who's well known to me. She's worked in the department at Groote for many, many years and works in Tygerberg too. She is Miss Physiology of the Gut, or shall we say Mrs. Physiology of the Gut. And today she's going to talk about the ABC of anal manometry, a subject which I think we all need to know a little bit about, and was the subject of her master's thesis, which was awarded with distinction. So hopefully she can simplify the concepts and show us pictures so that we can understand the principles of anal manometry, and then we can see perhaps what context we can put things into. So bear with us, and over to you, Sassa. Please share your screen and enlighten us on the ABC of anal manometry.
Okay, I just
Perfect.
want to...
You can go ahead.
We can hear you. That's good.
Yeah. Okay. Whoops, I actually want to go back one. No, wait. I just want to, sorry, I just want to, my slide. It's gone, yeah, I just needed to. How do I get one? Oh, wait. There we go. Okay, oops. Sorry about that. It keeps on jumping a bit. Yes, so I was actually asked to cover this very large topic, and that is anal manometry. So I thought I'll try and give you an introduction to high-resolution anal manometry, the London protocol, and the classification. I'm going to start with my take-home message, a little bit like serving dessert before the main course. So my take-home message, if this is the only thing that you remember, is that high-resolution anal manometry must never be requested as an isolated test, but as a part of a battery of tests for investigating anaerectal physiology in patients with continence and defecation problems or anal pain. The aim of this talk will be to give you a short background of the development of high-resolution manometry, indications for the procedure, performing the procedure, protocol followed, what are we looking at or evaluating. The most important thing is picture recognition, diagnosis, applying London classification, and then again the take-home message. So the background is that around 1980, conventional anal manometry was introduced as a commercialized test, and that objectively assessed anaerectal function in order to phenotype patients with pelvic floor muscle dysfunction according to the underlying pathophysiology. We were using water perfused or solid state with 6 to 8 channel catheters. And as you can see here, it was linear tracings that we tried to interpret. There was, however, a lack of standardization of methods for performing this procedure, the so-called protocols. The interpretation of the test and the normative data on healthy volunteers, especially age and gender, were all lacking. So since 2008, there was a new kid around the block called high-resolution anal manometry. High-resolution anal manometry provides a refined assessment of anaerectal pressure profile to identify structural abnormalities or anal weakness using pressure topography and interpolation. So high resolution actually just means a higher number of closely spaced circumferential sensors. So in other words, we were using 4 channels. We now have up to 20 channels, catheters with 20 channels. And this data was presented then through interpolation and computerized ways as a color contour plot. So the indications for anaerectal function testing, you must remember that this is probably one of the most performed investigations to assess anaerectal function. So we use it for, or the indications are fecal incontinence, constipation and evacuation problems, functional anaerectal pain, preoperative assessment, assessment of anaerectal function in patients with obstetric injuries, and to rule out Hirschsprung's disease. The preparation, not much preparation. We usually ask the patient to pass a stool before coming. They can have a light breakfast. If you do your digital examination and the rectum has feces in it, then we just give them a warm water enema. The patient is positioned on their left side with the knee of the top leg bent to 90 degrees, with the hips and the bottom leg, as you can see here, straight. It's very important, it's very important to first do a digital examination, because we want to assess what the tone of the sphincters feel like, and also the muscle bulk of your, all the muscles and the sphincters. Then we also, it's very important that the patients must understand what you're going to instruct them during the procedure, so that they know exactly when you say relax, that their sphincters are relaxed, or if you ask them to squeeze, they're actually pinching with the sphincters. So it's very important they really understand what you are asking for them to do. Then we use the catheter with a little balloon at the end, and we insert it. I use a water perfuse system, and I use my catheter has 20 channels. I position my catheter so that I have at least 3 channels outside of the anal verge, so that you've got a good area of atmospheric pressure. So because of this non-standardization, that they started an anaerectal physiology working group, and they, to try and get this standardized, they brought out a standardized protocol and also a London classification. And this is what we actually use in our lab. So there's a very strict protocol as to how and what you ask your patients to do. So what are we evaluating with this procedure? So it's important we're evaluating the tone and the contraction of your internal anal sphincter and your external anal sphincter. We're looking at rectoanal coordination to exclude or confirm dyssynergism, reflexes, and rectal sensation. We can look in more detail by looking at all the pressure values. We can see if the sphincters are normotensive, hypertensive, or hypertensive. when the sphincter contracts to see if it's normal or hypercontractility, and then the coordination on bearing down to see if there is not dyssynergism present. And then the important reflex that we're looking for is the rectoanal inhibitory reflex, and then rectal sensation that plays a big role in incontinence and constipation. We can evaluate that by using the anal manometry. So as I said, it's all about picture recognition. I think what you must remember is that, well, as I said, that we've got more channels, and what they did with interpolation, they could color it in so that you actually have one picture, and it depicts the warmer colors actually is implying that there are higher pressures, like here, and then the cooler colors are the lower pressures. So if you compare your anatomy to the tracing, you can see here's your anal canal, and here this pressure is your rectal pressure, your anal canal, and then here is your atmospheric pressure. So when you look at your image, or the image, you can see very clearly where your anal canal sort of stretches, because you just look at the pressure. Here you can see again the atmospheric pressure, and up here is the rectal pressure, and here is your anal canal. And this is the resting pressure, and the resting pressure is your internal anal sphincter, and this contributes about 80% of your rectal of your internal anal sphincter pressure. And that is also important because this gives you your continence. So in other words, if you're sleeping, if you're walking, your resting tone is very important, because that gives you your continence. When you look at the resting pressure, you can also sometimes see slow waves during the resting pressure, and that you can see it in normal patients, but you quite often see it when patients have anal fissures. Then you pick up the slow waves during the resting pressure. Squeeze pressure is your external evaluating of your external anal sphincter, and you ask the patient to squeeze for 5 seconds, and you can clearly see the increase above the resting pressure of your external anal sphincter pressure. Endurance squeeze is when you just ask the patient to keep on squeezing, and that's actually to see the fatigability of your external anal sphincter. So people with fecal incontinence, urgency incontinence, they tend to really struggle with the endurance squeeze. Your cough reflex is important. You again ask the patient to just give a good cough. And that is important because if it's intact, it implies that your sacral arc is intact. And also, if sometimes you'll find your external sphincter, when the patient squeezes it, it sort of is a low pressure. But if you ask the patient to cough, you can get a quite normal looking pressure. And that is sometimes because the patient doesn't quite understand how to squeeze. So this actually can tell you that there is peristaltic reserve of your external anal sphincter. Bearing down is very important because that sort of excludes or confirms dyssynergism. What you need to be able to evacuate, you need propagation of your rectal pressures, and you need your sphincters, your internal sphincter and your external sphincter to relax so that the stool can actually pass over the anal canal. Rectoanal inhibitory reflex, this is what we call the sampling reflex. And that is when your stool comes from the sigmoid and it falls into the rectum and it stretches your rectum. Then you get this reflex where your internal anal sphincter, you can see clearly, then relaxes. And it's important because if you cannot demonstrate that, then in an adult, it's usually implies that they've got a short segment Hirschsprung's disease. So I said it was all about pattern recognition. And as I said, the warmer colors are the higher pressures, the lower colors, or the cooler colors are the lower pressures. And if you just look here, this is a resting pressure. You can clearly see it's a low, much lower color than the previous one. So this implies that this is a hypotensive lower esophageal sphincter, and that implies that there's a defect of the sphincter, either structurally, or it can also be due to a neuropathy, like in, yeah. So here you can see again the squeeze pressure, and again, when you look at the color, you can see that it's a poor contraction, and that implies hypotensive external anal sphincter, and that again, it can be a structural defect or again a neuropathy. With a good, here you can see there's a good resting pressure. You can clearly see the high warm color, but if you look here, the squeezing pressure is very low. So there again, you can see that that is a hypertensive external anal sphincter. In this case, you can see the color is very warm, so that implies that there's a very high pressure of the squeeze pressure of the external anal sphincter, and this is in a patient with anal pain that we typically see. So to get back to the protocol and the classification, the upper people, the esophageal people, were sort of far ahead to the anal group, and they are now already on the Chicago version 4 protocol and the Chicago 4 classification for disorders of the esophagus. So the London protocol is now only on version 1, and the London protocol, you know, the Anaerectal monometry was used in the London classification, and they used these findings to classify the disorders into a minor, major, or inconclusive disorder of anal function. They used anal tone and contractility, rectoanal coordination, rectoanal inhibitory reflex, rectal sensation, and they added at the end a balloon expulsion test. And they came up with this London classification. I will be honest with you, here they look at tone. They've made it so complicated that I don't think, I'm not sure. I tend not to use it because it doesn't give me the answer to the findings that I get doing my monometry. So sadly, already the Chicago 4 did away with major and minor motility disorders of the esophagus. And I'm wondering if the London protocol will not follow this group and also realize that this is not quite a working classification. So we'll have to wait and see what happens. So coming back to my take-home message, high resolution must never be performed in isolation. So you can ask me, why a battery of tests? Well, we want to get a clearer picture of the mechanism of anaerectal pathophysiology so that we can phenotype our patients and then tailor their treatment of their problem. So you must remember, different tests evaluate different functions and structures. So we've got a whole group of tests. As you can see, here's your anal manometry that looks at function and a little bit of structure, and can look at coordination. It's a very inexpensive, really, procedure to do. Then the balloon expulsion test is really, you can do it in your surgery and it doesn't cost much. And between these two, you can actually sort of confirm dyssynergism. And only if you get these two positive, you go on and ask for the more expensive procedure, which is defecography. And the defecogram can give you sort of more information about structural defects like a prolapse or intersusception. And it can also give you perineal descent. And so it can give you quite a lot of information. We do nerve stimulation tests as well for the neuropathies. And then the endoanal ultrasound is a very useful procedure to confirm sphincter defects where you find a low sphincter pressure. So it's important to try and determine the pathophysiology so that we can, as I said, do a tailored treatment for your patient. And through doing that, I'm hoping that we can help our patients with fecal incontinence, constipation, and the pain syndrome. I added some references, and yes, that's the end of my talk.
Sassa, thank you very much. That was really well put into perspective, and I think it is obvious that that obviously the esophageal group have been at it for quite a bit longer and have at least reached some unanimity, and its clinical application is much clearer than in the anal situation. But I think that obviously, as you said, this whole thing is in perspective with the other tests. I'm not sure if you. There's one question here from Acqui, which says, "Do you perform this before? Do you perform this before colonoscopy if constipation, or where does colonoscopy sit in your algorithm to work these patients up?"
Well, I think it's probably also an age indication, you know. So for your colonoscopy, depending on what your age is, 50, I think it's now a little bit earlier. You'll probably first start with a colonoscopy when you do, especially if you look for constipation or change in bowel habits. So I think, yeah, I often in South Africa or here, I find mostly all my patients that get referred to me have had a colonoscopy.
Yeah, I think generally speaking, if there is a constipation history, I mean, but some of your patients may have incontinence. Would you routinely do it in young patients who might have an anal sphincter defect, or
colonoscopy?
Yes, in those.
No, in a young patient, you know, they don't sort of say what comes first, but I think in a younger patient, usually if it's a female patient, you're thinking, you know, sort of sphincter defects. So I think that the two go hand in hand, and it doesn't really matter what one comes first. So I think the anal manometry is very useful there. And if you get a low pressure, then you ask for a sonography. And I think because the anal manometry is cheaper and easier to do, then I think we'll probably start with the anal manometry and then go on to sonography.
Thanks very much. Paul, you've got your hand up. Can you also
have
perspective?
Can you hear me okay?
We can hear you very nicely. Please go ahead.
Yeah. Sasha, I'm going to challenge you.
Oh, okay.
I believe that anal manometry has got a very small role to play. And when you say we haven't been doing it for long, I mean, we've been doing it for 35 years, 40 years. What it is helpful with is putting numbers and training the Mark I digital probe. But it's putting numbers to sphincter pressures, etc. I don't believe it really changes management. Clinical history changes management. And anal ultrasound changes management, because endoanal ultrasound lets you make a diagnosis, sphincter ultrasound lets you make a diagnosis in the clinic with a patient who has significant symptoms, and you can see if it's a repairable defect. So, you know, I would challenge you that manometry has a place in anaerectal work, and it's useful. But I'm not sure it would be my first line, and it clearly is very useful in in medical legal work. But I'm not convinced that it's really useful in the clinical scenario.
Well, I disagree with you, because that's the whole point that they tell us every time, is that you cannot see anal manometry as an isolated test. You've got to do a battery of tests, and that is the whole point. That none of our tests have got can show it all, you know, and so well, if I look at the London group, they've got a one-stop unit where the patient comes in, they get everything. They get their anal manometry, they get their sonar, they balloon, they get their barostat, everything. So I think if you now go back to continence and incontinence, constipation, it's a complex problem. It's multifactorial. It's so complex that you need more information than just one or two. And it's again trying to get to the pathophysiology of the problem so that you can phenotype your patient and then really try and taper the treatment according to what you find. There is nothing like one shoe fits all. And I think we're underutilizing how we're actually looking at our patients.
I would certainly add to that the brain-anal axis.
Yes, for constipation.
So can I ask a question? Can I ask a question? Is that because before we get into any more cross debate, but obviously some of the treatment of incontinence very successfully is biofeedback. How does anal manometry help you select patients for biofeedback?
So if for instance, if you've got a fecal incontinent patient and the sphincters are, you get a weaker external sphincter, so then you can actually with biofeedback retrain them to exercise their muscle. So that's important. And then with constipation again, hypersensitivity of rectal hypersensitivity, you retrain the brain to actually feel the sensation of the first urge to pass the stool. So it really does help in those respects.
There's quite a few questions that are posted here that again sort of it's difficult to take in isolation, but one question, I think we'll just take this as the last question if you don't mind, but because we can get into all these function tests, and I think perhaps if I can summarize that these patients with really profound constipation, with incontinence, patients who've got severe anal pain and dysfunctional bowel emptying, they should be managed by specialists. They should be managed by specialist colorectal surgeons who have access to appropriate physiology and radiology and neural testing, so that they can put together the package and decide what's effective. Similarly, one of their problems is sorting out which treatment might be effective. And I think even Paul would agree that sometimes they make bad decisions about what is going to be the most effective therapy. So I think this is a situation in which I do believe the more information you've got, probably the better decision you can make. But you need to be seeing these patients on a regular basis. So I think we'll just answer this one question. What in the history and examination would prompt you to do anal manometry in a constipated patient versus treat symptomatically?
Now, remember, you only refer a constipated person who fails first-line therapy. So if you get a patient with chronic constipation, you go through all the normal, like you exclude drugs and all sorts of things, and you start off with your bulk laxative. So you must first go through the normal things. And so it's those persons who fail those treatments that you send for anal manometry. You must always first try the normal treatment.
Thanks very much, Sassa. I think we should call a halt there, and we're going to move on to our second talk. I think Paul's been resurrected by ESCOM, and he's
my battery. I'm going to share my screen if I can.
Yes. So over to you, Paul. Paul's has a specialist interest in Lynch syndrome. He'll give you the whole background to that, and as you know, he's a professor of colorectal surgery. And sort of spent most of his academic career here in Cape Town, with a short little period in the Free State just to finalize his thoughts on the matter. And now he's going to enlighten us on the topic of Lynch syndrome surveillance. Paul, over to you.
Sandy, can you see my slides?
Yes, we can. Very well. Thank you.
All right. So I'm going to talk about Lynch syndrome and the surveillance thereof. And if I go on, I have no disclosures. So the outline of my talk is, let's look at the extent of the problem. What is this colorectal cancer burden, and what proportion is Lynch? If we want to use the term Lynch, which is an American term. HNPCC is the old European term that is still being used and is probably a better term. Let's talk about inherited colon cancer, talk about its management, and then I'll try and come to some conclusions. And I'm not going to try and teach you to do colonoscopy for Lynch syndrome. That's a whole different issue, and that requires upskilling. So let's look at colorectal cancer. And if we look at Europe up here in the top, can you see my pointer? Can you see my pointer? Okay.
Yes, we can.
So very high incidence levels, 40, 50 per 100,000 in Australia, Western Europe, low mortalities. South Africa, relatively low incidence. And that incidence drops as we go down through countries in less and less developed countries. But look at the mortality. If you're in West Africa and you get colorectal cancer, you're going to die from it. Even in South Africa, Southern Africa, you've got a huge chance of dying. Now, let's look at population curves. Why do we see so few colorectal cancers in this part of the world? This is Europe, 2020, and this is age. And what you can see is a very small number of young people and quite a big group of old people. Compare that to where we live, where huge number of young people and very, very few people over 75. Now, is that why we don't see so much cancer? Maybe. Why is mortality so high in our part? Well, late presentation, poor access to healthcare, patient cost of healthcare can be astronomical. We're clearly under-resourced. We're probably under-trained for a relatively uncommon disease. And we have a very high rate of emergency presentation. And we're well aware that if you present with an emergency obstruction, colorectal cancer, you're going to do relatively poorly, both at the time of the emergency presentation and in terms of your longevity. And if you're talking about a disease that's 4 per 100,000 rather than 40 per 100,000, there's poor patient education. And we tend to see young patients with very advanced and curable disease. So let's look at the incidence. Okay. And this is world incidence of colorectal cancer and colorectal cancer deaths. And what we can see is that the majority of these incidence is 50s to 85 plus. And the deaths are in the older group of women die later. And if we look at the South African National Cancer Registry, and this is colorectal incidence, mortality and trends by sex. This was recently published, 2021, and that's what their graph looks like for this country. So what I did was I gerrymandered this graph a bit and put it there. And what you can see in males and females is that our incidence in the particular age groups is very similar, slightly lower than the world average. We just haven't got all these old people. So how do we reduce the incidence of colorectal cancer in our country? Well, in high-income countries, you can do population screening, and we can argue whether colonoscopy is the right way to go, or whether the risk is not worth the benefit, etc. That's certainly for average risk individuals. For high-risk individuals, there's no doubt that colonoscopy is the way to go. And what we are all arguing about is how often to do it. So, what about low and middle income countries like us? Our population is young. We have no screening at all. And we're not going to develop a national screening program for average risk colorectal cancer because of the low incidence. But the thing is, can we identify and provide surveillance for high-risk individuals? Is that possible? Well, the first thing is, does it work? So let's look at Lynch syndrome. It's a single mutation, and this is the disease profile in survival of brothers and sisters who one group has no mutation and the other group has the C1528T mutation. And if they carry the mutation, they die a lot younger than their brothers and sisters. Does colonoscopic surveillance in this group make a difference? These are all mutation-positive individuals who have been offered, who've had mutation testing and been offered colonoscopic surveillance. And what you can see here is that those who entered the surveillance program lived, on average, 20 to 25 years more than those who chose not to enter the program. So colonoscopy has a 20 to 25 year survival benefit in the mutation-positive individuals who enter the surveillance program. Now, what we were all taught is that colorectal cancer looks a bit like this. 80% is sporadic. There's some familials. There's a little bit of Lynch syndrome, and there's familial polyposis, etc., and others. And this graph this pie diagram hasn't changed from in the high incidence areas. But is this the same for the low incidence areas like us? The first bit of work we did was in the Northern Cape province, where we reviewed all primary colorectal cancer pathology specimens in the Northern Cape from 2002 to 2009. We found an annual incidence of 3.7 per 100,000, incredibly low. Median age of diagnosis, young. And 36% had at least one Bethesda criteria to suggest that we should take genetic testing further. So we went back a couple of years later, and we tried to find as many blocks of those patients that we identified with colorectal cancer in the Northern Cape. And we stained them because we had a shortage of time and couldn't cut enough blocks, etc. We only stained them for MLH1 and MSH2 gene mutations with immunohistochemistry. And remarkably, 21% of tumors were either MSH1 or MSH2 deficient. Now, you could argue that there's hypermethylation, you left out the other possible mismatch repair genes. Well, hypermethylation only occurs in very old people, so, or very rare in young people. So the hypermethylation is not really an issue. And yes, we would have missed the other possible mutations. However, only 22%? No. So we thought that, was this unique in, just the Northern Cape? Or is this something that is more generalized? In Cape, from Wits, used a different technique. He looked for microsatellite instability. In South African blacks at Baragwanath, Chrysali Baragwanath, and found that 15% of the colorectal cancers in their group had evidence of microsatellite instability. They didn't use Incidence. Another study from Cape Town, where we sorted out 70 self-declared indigenous African patients we'd seen through our unit over the years, all less than 50 years old. Histopathology in the blocks were retrieved, immunohistochemistry was assessed, and we found 37% of these people were mismatch repair gene deficient. This has now been published. I think you can ask Sandy that. But the remarkable thing about this, to me anyway, was mismatch repair gene abnormalities were in this group here, which were 35 to 45. And the other group of patients, the other 60-odd%, didn't have a mismatch repair gene, and they tended to be younger. There is, I think we found one gene in this group. It's certainly not a mismatch repair gene deficit. And it probably is going to be something that follows the classic pathway rather than the mismatch repair gene pathway. But this is a very interesting group across our country, across the continent. So this is a plot of known mutations in the area we work mainly by area code, by postal code. So whether you got 1 or 10 people in that postal code, it'll show up as a flag. So it doesn't tell you the actual number, but what it tells you is that I can't click on this because unfortunately it'll kill the. It's pretty nice when you do. What it tells you is that there are quite a lot of people that are currently known across our continent, our country, that are going to get colorectal cancer at some stage and need endoscopic screening. And that's purely work done out of Cape Town. What happened? What would happen if we had input from Durban, Bloemfontein, Johannesburg? The mind boggles. So what I've shown is the targeted surveillance of a limited number of individuals at very high risk prolongs life. In low incidence areas, inherited forms of colorectal cancer appear to make up a far greater proportion of the disease burden. Because actually what we've done is we've lost the sporadics. People don't live long enough to get them. It may be cost effective to offer surveillance to these very high risk individuals as a start. The challenges are identifying those high risk individuals, identifying causative mutations, offering the services, doing counseling, surveillance, safe surgery on an elective basis rather than emergency. We tried to set up a South African National Cancer Prevention Service associated with the NHLS, closely working with the NHLS, to try and strengthen these services across the country. And the plan is hopefully to identify high-risk individuals from the National Cancer Registry and from individual doctor referrals. The problems with the National Cancer Registry are the quality of the reports are very variable. They're mainly narrative, they can't be computer searched. So we are establishing a change in the reporting of colorectal cancer initially to a minimum data set. Hopefully we'll present that in 2 or 3 months' time to the surgical and gastroenterological community. What about your local hospitals? Well, shouldn't we do automatic immunohistochemistry on under 50-year-olds initially? Probably yes. Who should we do genetic testing on? Well, that depends on how big a family is. There's no point doing genetic testing if there's only one person, if there's one patient in the hospital who's got a cancer. However, if they've got brothers and sisters and children and lots of them, and a big family, then it's certainly worth trying to identify mutations through a sequence and then offer colonoscopic surveillance to high-risk family members. The surveillance itself is a problem. The polyp cancer sequence in inherited colon cancers, particularly Lynch syndrome and other inherited colon cancers, is much shorter than that of sporadics, about 2 to 3 years. Surveillance colonoscopy is very different to diagnostic colonoscopy. Diagnostic colonoscopy, you pop a scope in, the prep's not too good, but you're looking for a half circumferential lesion in the sigmoid colon. In this group of patients, you're looking for 2 millimeter lesions in the right colon. So the first thing is you've got to get there. You need excellent prep, otherwise you're not going to get 2 millimeter lesion. And you need to do a colonoscopy every 2 to 3 years, and maybe even every year when you get a bit older. If you hurt one patient, one individual in a family, one family member, you lose that entire family. So it must be painless. I don't know how you ever make bowel prep. This requires upskilling to do effective surveillance. You need to upskill the endoscopist and upskill the entire endoscopy unit staff to provide the optimum quality that you need to perform this sort of colonoscopic intervention. So in conclusion, the incidence of colorectal cancer in our region is low, but the mortality is very high. Population screening of any type, average risk individuals, is not affordable at the moment. Inherited colorectal cancer accounts for a greater burden of the disease than one would expect. The identification and surveillance of high-risk individuals prolongs the life of those individuals significantly. There are plans to try and implement the identification of those high-risk individuals, but we need to upskill colonoscopy dramatically, even if we can identify those individuals. Thank you very much.
Paul, thank you very much. Again, many of
I hope
those.
that's what you were thinking about.
Oh, I think very much so, and I think it touches on this whole business of colorectal cancer screening in Africa, and I think we share very similar views on aspects of that. So again, from Akwi, who's in the Mass General, but she's from Zambia originally. Are we really seeing less cancer? Well, I think Paul showed some data I've got lots of data. Leo Katsasidra has got data to say that things are on the increase, but still we are roughly 1/4 to 1/5 of what you will see in the high risk, high income countries, where some of the incidence is floating around, but we definitely see fewer. One of our problems in South Africa, and again, this is one of the reasons why I think Paul's initiative is so valuable, is that our population is distributed regionally. So we have this self-declared mixed race or colored race in which a significant number of patients of Paul's with Lynch syndrome come into. Am I correct, Paul?
No, I don't think so.
Are they maybe,
we're not. It looks like the big group that we're looking at, the MLH1, the HMLH1s, are actually probably Nguni people who arrived. The gene itself, the C152AT, is about 1,000 years old. We've aged it. And they arrived in the Western Cape about 10,000 years ago. And they walked down through Namibia. So with our blinkered eyes, they've been living in a Mediterranean climate, and they are not as dark skinned. So therefore you and I call them colored. But they're actually Nguni people. They're just, So the migration of the peoples of Africa are fascinating.
Yes.
And skin pigmentation is a result of sunlight. And as you move out of the tropics, you need to lose that pigmentation, otherwise you get rickets. So there's a big pressure, but we're blinded. We live in a country, we're used to seeing mixed race, so-called. These guys have been here 10,000 years.
Yes, I think that the term mixed is truly what it is. And I mean, obviously the other, what we consider the African nations who've migrated from the other side of the country, the Zulus and the Xhosas, again, they come with their own genetic heritage, which they've brought down. But traditionally, they didn't reach the Cape. They only reached the Cape recently when they started to migrate from the Eastern Cape. Traditionally, the so-called African population of African descent, from that route at least, didn't come to Cape Town until about 30, 40 years ago. And even then it was just a trickle. So it would be good to get information from all over the country, as you said, from Durban, from Witwatersrand, and from in the middle of the country as well.
Of course.
But that's going to give us much more comprehensive data on both adenoma detection rate and also the incidence, the true incidence of cancers in these groups. Again, I think you dealt with the fact that if you are screening and or doing surveillance in these high-risk groups, you want to have perfect prep and you want to be able to ensure that you pick up lesions in the right side. I think we've answered that. And there's another question here regarding, there was an opinion piece on CRC written in the essay Open Access Journal of Biomedical Sciences in January 22. I don't know if you've seen that article, but I think we both believe that population CRC screening is unattainable currently in South Africa and probably in most of the rest of Africa, if it's to be colonoscopy based. Whether there's a case for other mechanisms of screening, again, I think that's not really where we should start. So I'm not sure. I haven't read this this article, but I think we should be very wary of trying to say that we should be screening average risk populations in Africa for colorectal cancer. Perhaps
I would look at it another way. We've hardly got enough people to do diagnostic colonoscopy.
Yes.
For patients with symptoms. In fact, we probably haven't got enough. In fact, we almost certainly haven't got enough. So, you know, to start looking at a screening program for a very low incidence disease is actually this huge industrial pressure for us to do it, because they can see the number of scopes that need to go into the place, but it's not worth it. It really isn't.
Yeah. Do we have any other comments? Would anybody like to raise their hand?
There's something here about a pediatric patient, 8 to 10 years, found to have multiple
Yes.
colonic polyps. I don't know who wrote this.
It's from Acqui, who's at the Mass General. So I think what's our approach to FAP? Well, we do have, that's another group of patients that I think are well worth trying to have a national registry for. In fact, a colleague of Paul's and I wrote an editorial about where we should start with screening. And I think these groups of patients with inherited cancers are definitely where you want to start and where the most bang for the buck is. And again, pediatric 8 to 10 years with multiple colon adenomatous polyps. I think generally they wouldn't start to manifest themselves in FAP until they were slightly older. But again, one would be guided there. And again, if it's the first mutation, then you're not going to guess where it is. If there's a family mutation, then obviously if the patient has the mutation, that would be well worth seeing if you can check for it genetically. Then you will spare her the need for endoscopic screening if she doesn't have it, and clarify when she's going to start having to have a colonoscopy and a colectomy.
Of course,
again,
this raises the whole issue of let's say you have an FAP family with FAP. Do you do intrauterine amniocentesis and report mutation positives? Should we be doing that in Lynch syndrome? These are all the ethical questions that have to be answered. It's less of a problem if you've got both mum and dad who have Lynch. And we have 1 or 2 families like that.
Yeah.
Because now you've got a 1 in 4 chance of having a biallelic Lynch. And that is a big problem. But still, you know, the ethics behind intrauterine testing of pediatric patients for genetic tests is a problem that the geneticists have to deal with.
So I think we've really touched on quite a few topics. We've given some ideas, definitely as to why and what we should be doing with our limited colonoscopy resources. And I'd just like to call the meeting to a close here and thank both the speakers, Paul and Sassa, for their contribution today. It's been very valuable and interesting to me, and I hope to you as well. It remains for me to thank ECHO and ECHO India for their support in putting this together. And just remember that there is a feedback form available in the chat. We'd appreciate if you would do that. And if you have any colleagues who you feel this would be valuable for, or if you want to refresh your memory, this is recorded and is available on the website. Thanks again for that. On the Gastro Foundation website, you'll find the link to the recorded version of these presentations. So thanks once again, and thanks to the sponsors. And next up is GI hepatology, which will be a pathological potpourri. So tune into that next Wednesday. And until the next endoscopy gecko, I'll sign off just now. And thanks once again to everyone and all those who participated for your questions. Bye-bye.